Hey everybody, JT here with Dirtyberg, where training is continuous. Today we're talking about occlusive dressings, sucking chest wounds, and why placing the seal isn't always the end to our problem. Okay, so the chest is basically a negative pressure box. When there's a hole in the chest wall, air can get sucked into the pleural space instead of through the airway. Air likes the path of least resistance. There's an old rule that says the hole has to be about 2/3 the diameter of the trachea to become a sucking chest wound, roughly the size of a nickel or a quarter, and that gets repeated a lot. Life isn't always that clean. There's a lot of layers here. Skin, muscle, fascia, fat, all the tissue layers, even lung tissue can shift after penetrating trauma. Something we need to think about. Some wounds may open and close dynamically with the patient breathing, with their movement or our movement jostling the patient around, or even pressure. So we don't want to get tunnel vision trying to decide if the hole is big enough to cover. If you see a penetrating injury anywhere, from the neck to the navel, 360 around, just put an occlusive dressing on it and move on with your assessment. Seal the box, continue the exam. Now here's a part that a lot of people miss, especially newer EMTs. When we seal the box, we can trap air in the pleural space when there's a tear in the lung, obviously. If that pressure keeps building, we can worsen and create obstructive shock and code our patient. Here's a simple way to visualize it. I have a syringe here. We'll say this is the sucking chest wound, and here's our airway. Okay, and here's our diaphragm here, the black part of the plunger. When I pull back on this syringe with the hole open, air gets pulled in through the defect instead of through the normal pathway. If I cover that hole, the pressure is already building inside. Now that air becomes trapped. Obviously, it's an oversimplification, but it kind of helps us visualize how air entering the pleural space can eventually contribute to tension physiology. So after placing your occlusive, reassess your patient. We want to watch for all the things that we've heard of: increased respiratory distress, worsening hypoxemia, tachycardia, obviously hypotension, increased work of breathing, decreasing mentation, any changes to their chest rise and fall, etc. If they start to worsen after we seal the wound, we may need to briefly burp the occlusive dressing, which means open it up, to allow the air trapped to escape, and then continue our assessment towards definitive care. Now, this is separate from needle thoracentesis, simple thoracostomy, and tube thoracostomy if you guys are doing those out there. Those will have to be covered in another video because unfortunately people like to swipe after getting bored because there aren't enough flashing lights and noises every 5 seconds. At least that's what it seems like. But remember this: find the hole, seal the box, reassess the physiology, and keep training.